this is now my presentation. So, and you're a lively group, which is brilliant. And so I'm going to put a health disclaimer on this. I have tried for the last 5 years, having worked on securing excellence, been aware of what was happening nationally, to test out some of these theories within the area that I work in Greater Manchester. Some of it's gone well, some of it's been very difficult, and I'm just going to share how it's been, what we've been doing, what we've struggled with, and I think what we've achieved. So it's really just to give you a bit of background to the project so that I can bring you into the area of Greater Manchester quickly, in a nutshell explain what commissioning is from my perspective, and then just go through, as I say, what we struggled with and what we've achieved. And I sincerely hope I've got no mistakes on oral and maxillofacial surgery, which have been very, very clearly made in the Greater Manchester area as well. So from my background, I am absolutely fundamentally clear that clinicians make a difference. I've known that for many, many years. And where I see commissioning done well, good value, good quality, it's because the clinicians have been in a driving seat and a leadership role and haven't just been pulled in at the end to be told what's going to happen. And this Rising to the Challenge was published by the Health Foundation many years ago, and I still get it out to remind myself and commissioners that this is how we should be working. So it's fantastic to see that the NHS England are saying this very clearly as how it will be. In a nutshell, this is what commissioning is. I see it as public health in action. There's 4 quadrants to it. You start with what's the problem, describe it, needs, what is it, who has it, what services do we have to address it, how should we be preventing it, what models of care would be best to deliver, where's the evidence for those that they work. But we're trying to change the wheels on a car that's moving. Legacy services are there, things have been developed over many years, there's lots of opinions, lots of leaders. You try coming into this scenario to say, actually the evidence is that isn't the best way of doing it, and you come up against it or people become defensive. I think in this type of project, what I try to get people to do is take your own shoes off and look at the evidence, and that isn't very good quality at the moment. Designing the model of care has to involve the people who are at the coalface, who are in casualty at night, who are there in the surgeries. And then, once that's in place, you monitor it. And it's a consistent dynamic cycle. That isn't then in place for 10 years. You consistently look at the outcomes and back to needs assessment. That's commissioning in a nutshell. So back to Greater Manchester, with 10 PCTs across the whole of Greater Manchester, a population of nearly 3 million. We came to be one cluster, and the chief exec said to me, I want to understand dentistry. I then tried to get a picture of the health in Greater Manchester, description of all the services and the resources we had. What was the current issues and what were the priorities going to be for this cluster? Again, just to give you a quick picture, oral health is poor in Manchester. We've got nearly 6,000 children going in for episodes for children having extractions in hospital. And it's by the England standards, which is the little green bar chart, we've got very poor health. The 10 districts there there's only Stockport that's on the England average. And within Adult Dental Health Survey, we know we've got lots of people becoming dependent with dentate, lots of problems ahead that we need to start planning not just for this decade, but for the next. We had 440 contracts in primary care, including many specialist service providers, and 10 acute centres in Greater Manchester with 10 oral and maxillofacial units. That's the picture. I know I'm trying to do this very quickly, but it's really spring. So at the back of that, we have the NHS change agenda. We were suddenly in a cluster, a period of opportunity, and the chief exec wanted us to look at all of the legacy service models. There was clear evidence of ineffective use of resources in secondary care, and he wanted it addressing. The priorities were set for Greater Manchester. Of course, we needed to focus on oral health improvement, but the last point is the one that I want to bring to your attention. The chief exec of the cluster in a year wanted to see some of the commissioning and monitoring of dental services within the primary and secondary care actually to become a focus. Had there been a 40% increase in referrals to secondary care? Was there a need to back that up, etc.? These were the questions that were being asked. And this is just one line that came out of a board paper, that there was evidence in all 10 of the acute OMFS providers that a significant proportion of cases did not require that level of specialist intervention. And there'd been a year-on-year increase, up to 40% in some of the hospitals. And this just was not sustainable. We didn't have the resources to continually do this. Something had to be done, so I felt this is how the philosophy we use moving forward. Many of the commissioners had been trying to work with acute units, saying, is it appropriate? There were funding waiting list initiatives. I'm sure this type of picture is seen elsewhere. Pressure on the services. And clearly, we had to start to design differently for the whole of Greater Manchester. And the way we started to go about that was we needed to have some systematic care processes, some understanding of needs. That's where I would come from in health, in public health terms. And we needed the clinicians to think 10 OMFS units, lots of evidence that some of the care got in there. We needed the clinicians to become involved with us, to start to become transformational thinkers. This is the way it is. Could it be redesigned? And we needed to involve patients and start to capture outcomes. We understood that we started to want to see a single model of care across Greater Manchester, and Securing Excellence in Commissioning Dentistry is just a little title there. Was, of course, I was involved in some of the writing of that. So, of course, I'm thinking in this is how it's going to be in the NHS England. Let's have a try at doing things in Manchester in this way. One of the commissioners of the specialist services was working on general surgery, a very similar picture, 10 units, some very clear variation in quality of care and mortality rates. And he gave me these vital questions and said, ask these questions of the dental specialty that you're working with, and if lots of the answers are yes, redesign is absolutely necessary. And I asked the clinicians, we've had a number of workshops and days that we've worked on this, and there's some consensus that things aren't okay as they are, and redesign would be appropriate. And you can just see these vital questions. I'm sure if you think about your own units and where you work, some of the yeses may be, again, replicable elsewhere. So again, commissioning cycle, I would always start with needs assessment. I wanted to understand what the population need was via services. Had there been a 40% increase in people needing oral surgery and maxillofacial surgery? Had there been higher levels of head and neck cancers, fractured jaws? What was going on? And there was no robust data that I could rely on. We didn't know what best looked like. I didn't know which of these units was performing to the best and which wasn't. So we started with needs assessment and trying to make the case for change. One of the things that I definitely rely on is some of the Coleman-Hine recommendations on head and neck cancers, on the numbers of surgical teams, the numbers of cases that are required. And I think I started to build the case that we could be doing with larger units, and that 10 units, separate units for Greater Manchester, probably could be redesigned. Just part of the needs assessment I want to show you here. What we did was start to map, these are the 10 units again, but mapped across the rail networks and bus and transport. So there was a good argument that we could start to face to the public, that wouldn't it be better to have better care, better working lives for the specialists and consultants, stronger arguments for the training if it wasn't all part-time in different units. And this is just part of needs assessment work. What we had the biggest problem with was the data quality. It's inaccurate, some of it wasn't correct at all, even the description of a patient being an inpatient or an outpatient, which sadly has very much impacted on the resources we've got. So some of the methods that we had to use to obtain the data, how many surgeons have you got, how many days do you do oral surgery, is there any sedation, was really crude, but I'm just going to share it with you to start to build and show you how a needs assessment is done. We also found out that tariff, although there is a national tariff, there was lack of consistency in recording. I think there's 10 ways of doing things in Greater Manchester. So the current position was, although there were 10 units, the clinicians had organised themselves into 3 hubs. So we had a north, a central and a south network. The managers didn't know that that was happening. So the clinicians had already used some leadership skills to at least be sensible in organising hubs, because they had to cover on call. So I think, again, there was some real leadership being shown there, but I think the tensions of the individual units and their managers and chief execs at the acute hospitals were sort of almost a restraining force on those clinicians making a change. And then there was the United Republic of Bolton, seemed to be completely on its own in Greater Manchester. And I'm just going to share quickly a few slides just to show you what this type of needs assessment looked like. For example, this is a North network, and this is how crude the data collection had to be. You know, how many minor oral surgery sessions do you run in a week? Is it station? Is it local? How many theatre lists? And we're starting to see a real picture of very part-time work, which I think must be exhausting for the consultants involved and for their trainees. And I'm really beginning to think, is this the most sensible way, this really valuable resource we have of such specialist care being provided in such a piecemeal way? And I could immediately see that if you've got this number of theatre lists, would you not be better to have a dedicated theatre and a dedicated ward with trained skill mix there? And we just started to ask these big questions. And really, what was this telling us? So although they'd organised themselves into clinical networks, that hadn't been embedded into the commissioning or management. So they had 10 different commissioners and 10 different ways of measuring things. Again, we looked at activity. So again, I've just highlighted where the three bigger units were, trying to be very clean and not making any decisions, because the biggest problem we had was defensiveness here. People not wanting to be a loser or a winner. So when you start to share this information, and it was the first time all the specialist consultants, the leaders of each of these units had seen each other's activity data. So it was quite a sensitive thing to be sharing, and to see how many cases, some units had less than 1,000. And what really occurred to me, in each of these 10 PCTs, and in these 10 acute units, you're quite a small specialty. But when I take it a Greater Manchester picture, I think it has got a much greater power. We also, within the needs assessment, use the activity data to compare to other specialties within those acute units to see how the oral surgery and maxillofacial surgery, how much general surgery was going on, where was the trauma and orthopedics, because the clinical leads made it very clear to me that they needed to be co-located wherever possible with ENT, with trauma, and 2 big trauma units were starting to be discussed in Greater Manchester. And if we were thinking about smaller, bigger units, but with outreach to these others, I really wanted to make sure we could get a strong case for oral and maxillofacial surgery being in those trauma centres. And I think when you look at it across this patch, they then become a much bigger player. We also compared how the clinical capacity in each of those units compared, so where was ANT, to start to help, almost to bring an Excel spreadsheet, if you like, of points that's got strong, that's weaker there, to start to try and make decisions about the units. Again, we shared actual costings, and it just doesn't make sense. Some of the smallest units were costing as much as the larger, with double the activity. And overall, it's coming up to 13 million in Greater Manchester. Now, that's worth taking some service redesign over. But when I take one of the small units, Trafford, it's nearly £1 million. And it's up there with some of the other larger units with more activity. So our data's not strong. And I think it's the lack of coding or the way it was being coded. So again, it's very interesting when you do this type of detailed needs assessment. And it was the first time that the clinicians were actually being exposed to this type of pooled data. We didn't have the costings complete for 11-12. But what we now know is that tariff variation and what one hospital was claiming on one procedure was, and that's partly explained why Trafford was costing so much. And it was so difficult to get that consistency across Manchester. So the case for change, I think, has now been written. Very much I'm starting to work on, take it away from the activity and start to work on what recommendations are these clinical units not meeting. And Kalman Hines seems to me the strongest one, that a multidisciplinary team should be serving a population of 1 million. So we should have between 1 and 3 units of head and neck in Greater Manchester. That's where I'd be going on your strongest evidence base. And then start to work on, I don't want to take it down the line of 30 to 40% of the referrals here are inappropriate, because what has been wrongly assumed there is that 30% of the money, because the highest cost cases are in your more complex. So 30% of inappropriate referrals doesn't mean 30% of the budget. And some really naive assumptions were being made and bandied about. So I think we've really got to get better in describing the case. And again, we're looking at the multidisciplinary in other head surgical cancer areas, very much about 100 cases a year, and a figure of 300 per unit might be much more appropriate. So I would have thought it's much better for a specialty to have 3 surgeons doing those levels of operating together in a team with trainees working in that unit, but with some of the other units providing some of the assessment, follow-up appointments, but not the operating. And I think it's just having these big conversations and starting to share this level of data and level of needs assessment. We agreed as a group what the pathway needed to be, and not to be so focused on this inappropriate referrals, which I think we've taken far too many OMFS units down, and it's been to the detriment, in my opinion, because we need redesign across the whole of the advanced care complex pathway. Where is it most appropriate to operate? Where is the most appropriate place to follow up? Can we describe outcome measures in a more imaginative way and collect the impact of the care? And I think we need standard setting across that primary care, and I've seen many examples of isolated primary care oral surgery providers where the people picking up the problems are in the advanced care complex group because the quality wasn't there and the standards were not appropriate. So we want to see that as standard of care, and I think the leaders and the specialists have a huge, huge responsibility to get involved in what's going on in the primary care redesign and perhaps some of the supervision for it. At a risk of maybe loads more questions, I tried to do it visually in my head. The Department of Health were working with level 1, level 2, level 3 care. Level 1 being what they think general dental practitioners should be providing at the point of they've qualified, they're on the register, they should be able to do simple extractions. We know they don't all and can't all, but a provider of care, not every performer, is responsible for that and should never be referring level 1 work that they're currently being paid for. We see the OMFS teams very much sitting at the level 3. It's a scarce resource. They should be doing what only they can do. Sometimes it might be a level 1 procedure, but the patient requires level 3 care. And it's very hard in those ways to disentangle it. The oral surgery sits very much, almost half its time in OMFS, clearly linked, which is why the units are together. But a lot of their work could be at the level 2, sometimes needing to be in a hospital setting, and sometimes could be appropriately in a primary care, in a supervisory role. But I think there's very much more needed to get this pathway specialist and consultant led. And I'm just going to share one of the enablers from Manchester is because I was so upset by the lack of needs, was that we captured all referrals. And we have moved to one single electronic referral system across the whole of Greater Manchester. The last 3 PCT areas are going this month. Before, I saw see and treat letters. It was really poor quality, lots of level 1 stuff. After, we've now seen 92% of everything we need. It's electronic. If you're going to make a referral and it's going to cost us as a provider, as a commissioner, at least £200 for an assessment, you'd please do some work and you do an appropriate, careful referral. We can track it. Everybody's got an electronic unique number. The patients can track where they are. And consultants electronically look at those referrals. So it's consultant-led triage, and they have a directory of services. So they say appropriate for send back, it's primary care, but we don't send it back to the dentist who's referred it. That's a performance issue. We send it to a provider in primary care who's willing to take it, to level 2 care, and or into the hospital. So that's a sort of web page look at it. We've got unique reference numbers for every referral, and it's steadily increased. Then we're now accepting 6,000 referrals a month that the consultants are looking at in their own offices and surgeries. They don't need to be out of their own hospital environment, and it's part of their work. We're now getting 83% within 2 years. Initially, less than 45 had what we needed. 92% now have decent radiographs that are scanned and sent in. It can be done remotely, the triage. We had less than 40%. It was very poor quality. And now we have 100% of referrals with that central data capture of medical history that the clinicians and the specialists tell us they need to make a decision. And I don't think any of the primary care providers want to be the one that isn't doing it. So we've got a standard single model for recording and reporting. And now we need the same standard of coding and reporting within the specialist services before we can properly redesign a have-to-have robust needs. So we're aiming to introduce and test, and I've brought 10 copies of how do we capture that, how do we record in patients' records, and what's the appropriate tariff and code. And all the clinicians, we are hoping, will support and understand why we need to do this. and we'll be having clear, consistent pathways from referral to treatment follow-up, using the keywords. And we're collapsing down the ICD codes because there was about 10 different ways of recording caries. That's not appropriate for a commissioner or an oral surgeon to have to wade through those, so we've got collapsed those. And the clinicians have to understand how this system works. How does the HRG grouping work? How does the outpatient care? It may seem turgid and dry and boring when you really want to be doing clinical stuff, but it's so important when you see that we have to try and make the case for change. It's really important. You work with your public health colleagues to get this right. And those 10 copies are how we're going to try and test it out in Manchester. So I'm just taking you through from the whole referral. We've got an explanation of all the treatment options, and we're going to have a consistent coding. Right through to patient demographics, the medical history, the comorbidities, everything is just collapsed down and standardised. And we're asking all 10 units to do this. We had to even describe for them what a patient was. We found one hospital recording day cases as inpatients and some recording day cases as outpatients because they didn't want to breach. And it was less cost. Now, that's left us with less resources than we need, but they didn't get their breaching. I mean, this is the type of stuff that's been going on. So, again, we're trying also within this to record outcomes. So we're going to send those back to the clinicians for audit purposes and really to start to say, can we publish a sort of how are you doing guide for patients? So just to finish, and in summary, what's worked less well. This has been really hard work. I don't think at the end of this time that I've actually, and I said it to them at the last one, I haven't got yet in Greater Manchester a functioning, cohesive clinical leadership group for OMFS. I've had lots of different people come at different times. We've only had 1 year working on this. They all want to get involved. There's lots of reasons why that's not happening. The managers aren't releasing them. They don't see this as important. And I think they want to do it, but there's lots of restraining on them. Managing the tensions in their own units and their managers is very difficult, and I think I've had a light bulb moment about how we might do that. Some are making better pace than others, and I want to try and get them to work on how they might use the formalised supervision in primary care. And at the last meeting, we finally talked about the elephant in the room, because one of them said, well, you've essentially been asking us like turkeys to vote for Christmas, and I really hope that is absolutely not what's being done on here, but they see this evidence of inappropriate care being done as we're going to be cut, we're going to be changed, and that is absolutely not what this needs assessment or service redesign is about. And I'm so glad, I think by airing that, we can move on. The LPN structure is developing, and what I want to see is that cohesive clinical group, perhaps an SPR, perhaps an SHO in there, a consultant, actually be the specialist care group for minor OMFS for Greater Manchester, and they will be led by the leadership. So we work through this redesign. We now have, so I think, right, we don't have a cohesive group, we do have consultant-led referral management system. We've had a huge improvement in quality and appropriateness of referrals. We've got a checklist for the patient pathway. We now have that how to do it guide, how to code, how to record, and many of the clinicians are better informed than they were a year ago. And we've got that template document for testing. And this is one of the examples, like, you know, if this works in Greater Manchester and we can benchmark and get it light touch recording that makes sense to everybody, we'll rapidly be sending that to the commissioning group for dentistry to have a look at. Why reinvent? And I just think we need to think about what restraints are on those clinicians getting involved. This should be seen as part of your job plan. It's as important as doing a surgical list, not for every clinician, but for at least 5 in Greater Manchester. They have to, if you're going to be involved and you're going to lead, you have to be given time, space, and the ability to do it. Through all of this, and I don't know if Jeff Chew's in the room, but we find an absolute gem. He is, he's at the back. We find something that Jeff had developed very, very late in the process called SurgiNote. I've sent it up to PHE Informatics. They think it's absolutely brilliant, and it should be adopted. And he'd written a publication on it. You know, what's holding us back when something this innovative and excellent is being developed by one of your clinicians? And we'd like to see that happen. And just to finish, I think clinical leadership investment in you as specialists and surgeons is hugely important. And one of my biggest inspirations for public health was a maxillofacial surgeon called Jonathan Shepherd, who did some leadership work. He used public health principles to prevent facial trauma and actually has had more impact on public health than any of the consultants in dental public health that I work with. So I would never underestimate the value and contribution you can make to this. And if you don't, who's going to do it? And I can't work alone. Thank you.
Thank you. Can you see that what's trying to be conveyed here is a direction of travel? And I hope you're picking up some of this. Yes?
That's Talents from Oxford Training. I'm quite interested in the beginning of your presentation. You had a figure there saying 40% increase in the number of referrals to secondary care. I presume that's for oral surgery as well. That's very interesting to come on the back of like 10 or 15 years of huge emphasis on access to primary care, and very lot of political push, and on a lot of money thrown into primary care. And you can't help thinking that all that money has been, I say, wasted on sort of certainly making primary care providers richer, but not really improving public health, and certainly leaving the secondary care providers to pick up the pieces. And I wonder if continue that same trend for oral surgery would just make things worse. But I'm quite pleased to see that you've actually, at least on the examining table, managed that secondary care providers are involved in the, not just in the decision-making process, but also in the provider side.
Yeah, I agree. It's a squander of resource. It's effectively we're paying primary care and then we pay secondary care, and it's not sustainable, and it has to stop. We have to use the resources we have more effectively.
Yep.
Thank you very much for a very interesting presentation. I'd just like to draw everybody's attention to analogous situations which you've referenced, like trauma, for instance. Now, if I can just set the scene for just a minute or two, exactly what you've said there needs to happen with OMFS and oral surgery in general referral is what's happened and been rationalised for major trauma through this country. In London, we've been live now for 3 years. The rest of the country has been live for 1 year. You can't have a major trauma centre on everybody's backyard. They are now part of operational delivery networks in which you have a hub for which you could analogously see an OMFS unit, and a number of trauma units that feed in through a network which deal, they have not got the capability to deal with every stabbing of the chest, etc., but they accept them and they escalate them. And they function then against guidelines, and they function against outcomes. Now, one of the major things for trauma, and this comes back to Ian Hutchinson's point, is about the collection of data. I am now flogged, and I flog others against our performance data, because I can tell you how long it takes to cover a free flap for an open tibial fracture, and that is the same for every single network of the 27 in the UK. So that peer review is outgoing, and what's more, that is driven by best practice tariff. So if somebody doesn't get tranexamic acid in the first 3 hours, I lose £2,800. And that's the same for getting the chest drain.
Rob, I mean, I'm getting the message from you is that, in fact, you've adopted, prior to Colette's even doing it, this concept of measuring something, then hitting a standard. And is that what you're proposing?
Everything is measurable, and you're quite right, Mark. The way that the direction of travel with Bruce and the others and the CRGs is this clinical reference group will set the standards.
Yep.
They will go to the National Commissioning Board and they will say, that's your specific contract, yep, and that's what you have to deliver against what is benchmarked. You will be measured against it, and we will incentivize it year on year by changing the contract. You will also then have best practice tariff, so you'll be incentivized for it. And you will also then have sequins that come in each year, which will then incentivize that. So that's the direction of travel. And from collecting data, just on this point, the Trauma Audit and Research Network from that august institution of Mount Salford University has been instrumental in driving that. Everything is data-led. I will get an outcome every month on my performance, and that's where OMFS needs to go.
I mean, so if I just paraphrase what you're doing, you're actually backing Colette's model, and you're saying this is, our services are going to be rechanged relating to that, and we need to be involved. Nigel, you were putting a hand up at the back.
Thank you very much for letting me speak. I'm probably the only person here, apart from the cameraman, who's not dentally qualified. But can I come back just, facts are facts and fantastic, and public health produce huge amounts of data that can be worked on. Your case for change is proven, there's no doubt about that. You've got the biggest hearts and minds selling project if you're going to reduce 10 units to 3, but you're actually only going to invite 5 people along, because 5 units are going to be disenfranchised at least. So let me finish 1 second, then come back. I may have misheard it, but I thought you said that because of your numbers, you really needed 3 units. The other little sentence that came out was this dreadful, excuse me for using that because I wouldn't want to be impolite, but this concept of co-location with trauma units. OMFS does not need to be co-located with a trauma unit. Trauma surgery of the face and head and neck does. We have to go down a route of separation of trauma and elective. Now, Rob has quite rightly said in London we've been doing this for 3 years, and we are in a mess where we have elective surgery going on in big numbers in the same location as the trauma. And that's across everything, not just OMFS. That's T&O, general surgery, cardiothoracics, you name it. So that was just my point. I think the model, the case is proven, but the model is not a co-location with the trauma unit. It has to be trauma and elective separate.
Take your point. I didn't say we'd have only 3 units. I think I said that that would be 3 operating units. That doesn't mean all 10 would close, because we might want to see some of the units stay open to provide local anaesthetic, assessment, close to home. We just wanted to see theatre lists be more co-located. And when I use the term co-located, I'm paraphrasing what the clinicians have been saying they wanted.
Stop them saying it.
They wanted to be co-located with other surgical specialties and changes that were happening in Greater Manchester. And they have told me that ENT, trauma, those are the ones that they would be more keen to be in the same unit as. I have to take that clinical advice and leadership into account, and that it may be different for London, but for Greater Manchester, that's what the leaders were saying. But that's the political
problem, because the trauma units will stand up and say, oh great, everything's going to be with us. Yeah. And it's the wrong model.
I think what will happen, and I think what I tried to illustrate, is that it's not a specialty in isolation. Safe and Sustainable is part of the bigger project that's happening in Greater Manchester, looking at acute units and hospital provision, and it's just part of those decision making. So when it decides is there will be what is withdrawn from one hospital and strengthened in another, it'll be part of those discussions.
Rob, I don't want to get into a trauma thing, etc. Like what I'm trying to get a thing across to all the juniors coming through, that life's changing, is going to be dealt with on a data-related thing, as opposed to arguments, which before there's going to be a reconfiguration. And you have to be part of this. That's what I'm trying to give you. I don't think there's a right answer at the moment. It'll come out as we go ahead.
I might just say, I think
really
Nigel
quickly.
and Colette is saying exactly the same thing. People have got to get their heads around this is about an operational delivery network.
Yeah.
And there are various levels of delivery of care within that that geographical network.
Yeah. Just another final comment, when you mentioned about only 5, we cannot possibly have every single clinician in a specialist services across Greater Manchester part of this process. You would always choose, some people have got innate leaders, you know, we need to develop some of the people within the specialties to work on this. It won't be everyone's interest area to work in. I don't think you can have everyone. So you need to say, who are the best 5? And they would be used to share back with their peers and with their other units. They become the resource within the project.
No, absolutely. And this is where we can help in BAOMS to try and initiate it. Hutch, just quick.
I think excellent presentation. I love the formalising of data collection, so that you've got it clear. There are a couple of points I wanted to make. The first point I wanted to make was a very minor point. I'm puzzled why you had Bolton down there, because Berry, Bolton, Blackburn,
It's all just technical.
presumably all of Manchester, and they're all part of the same group. The second thing, it's only a minor point, the other point is more important. The other point is that we're talking about service here. Actually, in this room, I would say 90% of the people are trainees. They have to learn how to do this. Why did of referrals of patients who shouldn't have been referred from primary care in the first place because of changes in remuneration of dentists. They didn't want to do that work. They wanted to send it off because it wasn't cost effective. That was probably the reason that the 40% increase. So there are other things going on here other than our desire to do it. Every specialty has to treat minor surgery. So I think Nigel's a vascular surgeon. He has to do varicose veins as well as fempops and things like that. Our minor surgery is oral surgery, which is taking out third molars. That's how we cut our teeth. That's how we learn how to do things. We still do it. So that's one point. We need to keep that within a specialty because it's vital for the training of people. The second thing is that if we're going to have practitioners in primary care doing third molars, then they need to maintain their CPD. And one of the best ways of maintaining their CPD is working within secondary care units and tertiary care units, continuing to learn within the oral and maxillofacial surgery umbrella. So that's the
I totally agree. Which, when I tried to put it in a visual, you know, I've heard these arguments in Greater Manchester. I think I made very clearly, level 3 is clearly OMFS and some of the very detailed work. And it's sitting alongside, integrated sometimes, separate sometimes, that's for the specialties to decide. It's all in level 3. It's in an acute setting. But I see the oral surgery much more has got opportunities for supervision and outreach work. And that's why I tried to put that in the model of level 2. And I'm seeing that as part of job roles, not to just ignore the quality and standards that are happening in primary care. And I also take your point, all those referrals were made for economic reasons, for contract change reasons, but the acute hospitals accepted them and charged for them. And we have to start to say that's not an effective
Sunderland has a model. Sunderland has a model where oral and maxillofacial surgery go out into primary care, delivering that care all the way through from primary, secondary, or supervising primary, secondary, and tertiary.
But they need to have their feet in an acute setting as well.
Okay, I thank you for coming all the way down from Manchester. Thank you very much. No, it's fine. Okay. Yes, thank you.